So today you guys asked me to talk about patellofemoral arthroplasty, since that's a little bit more of a unique area you guys have seen. I know that Julie had taken care of one of my patients, and she asked a lot of questions during that working with her about the procedure and sort of what is this thing that you're doing now. And, I'm seeing you do more of these, and tell me a little bit more about it. So hopefully today gives you some information about what we're doing and then the sort of the future of what we're doing with this. So I started doing this procedure actually after fellowship, because I have so many patients with patella instability, patella realignments, and doing a lot of complex patella stuff. And the problem you have is that you get to patients that can't be helped with cartilage stuff. And so you don't want a 30, 40-year-old, mid 40-year-old coming in being told there's nothing you can do, and everyone's telling them they need a total knee. And so really we started saying, why don't we have this other option? And we'd heard plus or minuses about it from various different parties, but really it's just understood, and the data is not really well understood by standard joint surgeons, because there's really like the joint surgeons, they don't do many of these, and the sports guys, they don't do many of these. So there's really no one that does that many of these. And so we kind of want to hone ourselves as to the people that did the most in the area, and then what can we do to titrate to get better results, right? Because this is a different patient population than the standard total knee. It's not just about alignment. You have things that can go wrong in terms of instability, et cetera, which you can correct if you understand those parameters. So we'll go into that briefly. All right. So really the patellofemoral joint anatomy, you have the osseous anatomy. This is the bony constraints, the patella and the groove. Then you have the intercondylar groove, and then you have the diameter, obviously, of the lateral condyle is larger than the mediofemoral condyle. And then you have the ligaments, which are part of it as well. That's the static stability. You have the MPFL ligament, which is the most important one. And then your retinaculum and the patellofemoral patellatibial ligament. And then this is important to understand is the activity. I know you guys all know this as rehab and physical therapists, but really you put a lot of weight on a lot of force on your patellofemoral joint when you get past 90 degrees of flexion. And in squatting, it's almost 20 times the body weight. So majority of these patients will have complaints really with going downstairs, flexion past 90, and squatting, as you guys may have seen in some preoperative evaluations of patients with a lot of patellofemoral issues. So arthritis itself, patellofemoral arthritis is fairly common in patients over 40 in certain patient populations, but it's about 9% of patients over 40 have this patellofemoral isolated. It's much higher in females. I mean, I would tell you a majority of my patients are female that get this. It's because they have higher patellofemoral malalignment and higher dysplasia profile. And so that's one of the main reasons people get this. So patellofemoral osteoarthritis is really related to abnormal joint stresses. The most common factors, again, are malalignment. So patients in valgus, so valgus knee, they have trochlear dysplasia, they have patella instability, so their kneecaps pop in and out, and they have femoral aneversion. And all of these things you need to look at when you're assessing a patient about what the best thing to do is. So what are the causes? Again, we kind of mentioned this as the acute ones. So patella, fractures of the patella, traumatic patella dislocations, tendon ruptures, direct impact. I've done surgeries for all those different areas in terms of patellofemoral replacement. So people that have had an acute fracture that was never fixed, recurrent dislocations, someone that had a patella tendon rupture, was fixed poorly, ended up degrading and had isolated patella arthritis. And so there's all various features and different things that people get, things you have to look out for when you're doing these procedures secondarily. And then chronic, so overload from activities, weight, which is a big part of this, which we'll discuss very briefly, lower limb malalignment, and then OCDs. So patients that have had multiple OCDs that were never treated eventually goes on to arthritis, where they have kissing lesions, so the patella and the trochlea are affected. So all of these things you need to be aware of. This is important. So you may see x-rays of a patient and they look horrible and they tell you there's very little pain. So you don't just do surgery on that person. Now, again, this x-ray is extreme. We have a patient that looks just like this that we're doing bilateral patellofemoral replacements on. So we do, this is more the extreme version, but some of these patients don't have pain. You gotta be careful of the one that says, oh, I just want my knee to look straight again, and their kneecap sitting out to the side, but they have no pain whatsoever. So I don't always treat x-rays. X-rays are helpful, but you wanna make sure that they correlate with the patient's symptoms. So we won't go into this briefly, but we can look back on this lecture. These are sort of the ways to treat these medically with anti-inflammatories, steroids, hyaluronic acid, et cetera. And then you have the long list, which we won't go into now as well, of orthobiologics. So, the PRP options, which we offer patients occasionally. There are the stem cell options too. And that's for another time to talk about. So surgical management, again, it's sort of the same thing I talk about with any of my isolated medial, lateral, condyle, and patellofemoral joints in terms of how I treat cartilage patients. If it only is one or two of the compartments, it may be a correctable problem. But in my experience, the number of patients that come in that have been told that they need a full total knee replacement that is very incorrect is very high. And that's a benefit of my practice because I can offer them something that saves their knee. And in this case, I can offer them something that's not a total knee replacement, and it's much more natural and something that buys them more time, which is always what we're about. Can we get you higher quality of life years, buy you more time to avoid a knee replacement as long as possible? And so there's various levels of treatment there's arthroscopic debridement. We don't do that very often, but occasionally if there's a large condylar defect, we can clean it up and that might give some relief. Tubular osteotomy is a very powerful procedure, and we do that a lot of times in combination with other cartilage procedures, but sometimes in isolation that can be an effective procedure. I've seen some kind of wild tubular osteotomies done from outside areas where I didn't think there was any way those were going to work, and the patient ended up doing pretty well. So I've been surprised by some of these with patients with severe issues. Then there's partial knee replacement, which we'll talk about, which is a patellofemoral replacement, and then there's total knee replacement, which hopefully we don't have to do for a long time. So again, we'll keep harping on this, but you got to understand everything if you're going to start doing things like this, especially in isolation with patients, because you do one or two poorly done ones, patients don't do well, they're not happy, and then you get either a bad reputation or you just have patients who are currently not doing well and people are starting to question the procedure you're doing. So you want to be really sure that you have tight indications. So, especially for alignment, do they have instability? How are you going to correct all these things? Can your replacement do all that work for you, or do you need to add something else, or is there something else you need to do? And this goes for any type of joint that we work on, whether it's the medial, the lateral side, or the patellofemoral joint. So if it doesn't need a cartilage, if it doesn't need a replacement, we have all these different types of cartilage procedures that I do. Most of the ones I'm doing are Macy and cartilage transplants because a lot of my patients come with 3 or 4 failed surgeries, and they get more challenging as you go from right to left. And you got to make sure you have, a lot of these procedures have concomitant surgeries, like the one I just mentioned before. We just did a high tibial osteotomy with a cartilage transplant. You got to really make sure that the environment that they're in is stable and something that will allow for the biologics to work. So management surgically, uni compartment arthritis. And again, a lot of people see the medial unis. Some people see lateral unis, less common. And then the patellofemoral. So the two on the right are the least commonly seen ones, and some people don't even hear about them. You don't want to forget about the patellofemoral replacement, especially in patients under 60. I've done patients older than that, but really there's that 40 to 60-year-old sweet spot where the patients likely will have very little cartilage damage to other parts of the knee. And that's really the way that they get the best results. So we've seen patellofemoral replacements with over 70% success at 10 years, and people always ask this, and I'll show you a quick slide at the end. And for unis, uni compartments, medial unis mainly, they do really well at 10 years if done properly. Again, making sure they have the right alignment. So what are the indications for patellofemoral arthroplasty? Because most people don't really know these. So basically isolated primary patellofemoral arthritis. And this is hard because a lot of patients have other issues going on. So you got to really make sure. I always get an MRI to check. And I actually will do a scope during the procedure first to make sure that everything looks like it did on the MRI, and double check everything else in the knee. Trochlear dysplasia, again, a lot of these are patella subluxation, which most joint surgeons don't get to see. So the patients that come in, I've had multiple patients. I'm just doing a guy that had probably 200 dislocations and his kneecaps just sitting out to the side. It's completely unfixable by any cartilage problem. And so how do you fix that problem? Because if you just do a regular patellofemoral replacement, that'll fail. That'll keep dislocating. Failed extensor mechanism unloading procedures. So that would mean, tibial tubercle osteotomy that still didn't work, still has pain. Usually not a hard indication, but over 40 years old. I have had patients very infrequently under 40. I have a guy former Navy diver that's 37 that has one of the worst looking patellas I've ever seen. And we're doing, 3 different procedures on him all at the same time. But, he's 37, his kneecaps are stuck and they're formed on the outside of his knee. There's nothing I'm going to do outside the replacement that's going to make that better. Absolute indications. Now, again, a tibial-femoral osteoarthritis. This is always a challenging one because if you have a little defect or a small little cartilage hole, is that something that you should say you're no longer going to get that? You're going to get a knee replacement? It's always dependent. You might have seen the video I had recently, which I did a cartilage transplant on somebody. So you got to think outside the box on these patients, because if they have pretty good looking plateau and meniscus, you can add other things and you don't have to do another second replacement on them. Patellofemoral malalignment, it's all relative. Knee instability, again, ligaments are unstable like ACL, PCL. Those are obviously contraindications. And then a lot of valgus, which would mean that they're going to have increased risk of dislocation. Because again, you don't want to do this on somebody for dislocations and then they start dislocating their kneecap, because that's going to destroy the implant and you're not going to have a good result. And then obviously acute infections. Patella baja is an interesting one. That's a relative contraindication, but we want to make sure those patients can have overload if you do the surgery incorrectly. So what are the advantages over cartilage procedures? I love cartilage procedures. I love to save the knee as much as possible, but it's a tough surgery. And I sometimes give patients over 40 the option. I said, you can get a patellofemoral replacement or you can do the cartilage procedure. The success rates of the patellofemoral replacement are higher, but it's permanent. And the cartilage procedure are lower success rates, in the 70 percentile, but you have a good chance of saving your knee. And so I'll let patients sometimes make that decision. So, over 90% satisfaction, faster recovery for the most part, 4 to 5 months. Now, you may have seen, if you've seen in my patients, some patients do take 7, 8 months. They do continue to have occasional swelling here or there. So, not everybody's in that number, but that's usually the norm. And then, you get full weight bearing. You do it. This is done at the surgery center. It's done outpatient. You're full weight bearing. You can start working your knee, start moving your knee. It's different than the cartilage procedures where they're non-weight bearing for 4 to 6 weeks. And really, it's a more progressive to 9, 10-month recovery, if not longer. So I think we're in the matter of time. I won't show you my technique, but this is the video from my website, which you guys can look at. It shows how I do a patellofemoral replacement. This is the survivorship analysis. This is a good one if you ever talk to your patients and they ask you about this. But you can see 15 years, 75% are still intact. The number one reason that they go on to progression is tibial-femoral osteoarthritis progression. So 38% of them get arthritis in other parts of their compartment. The good news is it's a relatively easy revision for the joint surgeons to kind of remove that implant and do a full knee replacement if they need it. So it's not something that you're not getting them into a challenging situation if they fail at 10, 15 years. And most of my patients are totally fine understanding that because they want that quality of life back and they don't want to have that risk of a knee replacement. Because you go from a knee replacement at 40 to a revision knee replacement at 60 or 50, that's a much worse situation. So osteolysis is a potential complication. It's much lower than total knee. I haven't had a patient with it yet. But over time, we may see more of those. Infection, it's lower than total knee, but you don't want to have that, obviously. The lateral knee swelling, we do a pretty large lateral release. So patients are always surprised about the sort of amount of swelling they have on the outside of the knee, because remember, a lot of them are stuck laterally. So we do this big release and they actually are surprised at how straight their kneecap looks afterwards. But that comes with the fact that you really can't fully close that lateral side. And so it swells for a little bit longer. You can have maltracking. That's if you don't really fully understand what you're doing. You don't look at the parameters. This is why people really have to understand the patellofemoral joint if they're going to start doing these. Patella fracture, you don't want this. This is by cutting the patella too thin. So again, not all procedures are perfect. 16%, I wouldn't say that number is accurate. I would say that some patients still have some mild recurrent pain. It could be from either the fact you still have other issues going on. There's other patellofemoral stuff. As you guys know, if you have weak quads, you can still have anterior knee pain, even with a perfectly normal cartilage or normal implant. 14% loosening, this is over time, and then 10% maltracking. I think a lot of the maltracking is micro instability rather than actual instability of the patella, but these are some of the things that can progress and cause the need for further surgeries. So this is the future of patellofemoral replacements, and this is really important. I think if you're doing these, this is sort of higher level, but these patients with these larger TTTGs, you want to consider doing potentially another TTO as well, because this implant will do really well correctively. Like I can correct someone's alignment pretty far over to neutral without having to do any other surgery on them, which is really cool. And you can't do that with any other procedure, but it only can do so much. Another thing is if they have instability, most of my patients who are currently dislocating that need this, I add something called an MQTFL. You guys may or may not seen, I've only done a few of these with my patients because it's just not that common. But this is a way you can do like an MPFL reconstruction on someone with this, and you can actually keep them more stable. And I have a lady that had recurrent dislocations, and I did a patellofemoral with this, and that was really helpful. Or I've had ones that have had a patellofemoral from somebody else that were dislocating. Just adding this alone can be really effective. And kind of a little more crazy is if they have other issues that arise at 2 to 3 years out, you can also do a medial and a patellofemoral replacement at the same time. Much less commonly done. And again, this is how I do an MQTFL with a. We're not going to go through it all right now, but basically that's on my website as well. You can see how you add the MQTFL with the patellofemoral replacement. I think we have 10 minutes for questions. Hopefully, sorry, that was a whirlwind. But do you guys have any questions?